cracking as everybody's time is precious. Has everybody here received a copy of the agenda? Yeah, great. OK, I'm going to share the slides in a minute and just which has got a rough agenda on. We are also recording this meeting so that we can share a copy of the recording with participants who, well, with everybody, whether they attend or not. So just to make you aware that we are recording. Please use the chat function if you've got any questions or if there's anything you think is pertinent that you'd like to share. Because I'm doing this on my own today, I used to have somebody to be the administrator to keep an eye on chat, so I may not be able to do both, but I will go through the chat when I'm preparing the paperwork to share afterwards. So if any questions aren't answered or there's any points that aren't shared as part of the presentations today, then I will get round to it. Of course, you can use the hands up function or just raise your hand or just turn your mic off and turn your mic on and shout out. It's all relatively informal. I've had a couple of apologies for the speakers today, so we may actually finish before time, which would be great because I know one or two people have got to leave early anyway. What we will do is where speakers can't make, there's one speaker that was under AOB anyway, she wasn't on the agenda, where those people have got information that can be shared, I will share that with everyone as part of the paperwork. So if I just share my presentation again. So the agenda today is going to be looking at something called the ICS and why it's important that we understand or get a handle on what it means to us. We're going to be looking at a couple of initiatives that are taking place in Enfield that residents can be involved with, which will influence healthcare provision and also influence their own health. One of those things is patient participation groups, and so Litsa Worrell, who's on our call today, she will be telling us about her programme around this work. We want to talk to you about being involved in a film locally, about what's been achieved locally around the themes of health inequalities. We'll get an update about the community participatory research programme, which has been spoken about before at this meeting. It's a standing item, and hopefully somebody from Middlesex University will be here later in the meeting if they're not already here. So my apologies if you are already here, and we'll hear about that. There's also a healthcare system leadership training opportunity that I want to tell you about, and hopefully we'll be finished well before 12:30. Just by way of a reminder, the aim of these events is as per the information that's on the screen. So it's about connecting people, whatever part of the organisation you're in, within your own organisation, whatever part of the system you're in, within the system that you're part of, whether that's public health, local authority, healthcare, adult health and social care, NHS, the voluntary sector, and I think that covers it all. Well, maybe, I suppose, social enterprises. It's about connecting us around the themes that we're all working towards, and in this case it's around health, the reduction of health inequalities. The purpose of this meeting is to update everyone about current activities and priorities, and to hear from people that are delivering work and activities that are happening in our community that are making a difference. And the objective of this is that we listen to one another and learn from one another, and of course to increase our networks. So see, this is what happens when you don't have a facilitator. You have to do it yourself. So does anybody have any questions about anything that I've covered so far? Everybody understands why they're here. Lovely. So what I'm going to just do now is I'm going to share with you a video about something called the ICS. Can I have a show of hands, whether it's fingers up or the emoticon things? Is everybody, can you give me the thumbs up if you've heard of the ICS? It's not, doesn't matter if you haven't. I just want to get a gauge. Yeah. Okay, some people have, some people haven't. Great. Okay. Now, has everybody on this call, are you aware of the, well, we're all aware of the NHS because if nothing else, we're registered as a patient with it. Has everybody heard of the CCG, clinical commissioning groups? People are aware of that, yeah. CCG was the mechanism by which the NHS funded NHS services, which are broadly in two spaces. There's secondary care and primary care, and primary care is your GP and secondary care is generally what you are referred on to, hospitals and other specialist services. Now, I know there are people on this call who know much more about it and are in that system, and they will be able to correct me, but broadly speaking, that's what it is. Now, the system has changed massively. So in January 2019, the NHS launched its new strategy. It's just gone out of my head what it was called. Anyway, it'll come to me. Sorry, there's been so much information shared in the last 2 years. And in that, and by July 2019, the NHS had it was essential, or it was mandatory, that GP surgeries, if they were going to continue to receive NHS funding to provide a primary care service, pulled together in what are called primary care networks. And I've got a map of the Enfield one that I'll share with you shortly. So in Enfield, there are, I think, 49 GP practices or thereabouts, and they were pulled together in 4 primary care networks. Now, that was the sort of first major change. As part of that work as well, at the same time, some new roles came on board within the health sector, within the NHS, called social prescribing. And social prescribers, and we may have some on the call today, are people that are funded by the NHS to work with patients around socio-economic factors that are affecting their health. Now, over the last 18 months, the actual system at a higher level within the NHS has been going through a massive change. And by the 1st of July this year, the system will be divided across England into 42 integrated care systems. And the CCG, the clinical commissioning group, is no longer, groups are no longer in functioning, and I'm going to give you some details about how it affects us. Now, this is all at a very high level, strategic level in Enfield, but it's important for context. But what I'd like to do first of all is show you a short film. So if you bear with me, I'm just going to share my screen and then run the film. Okay, I'm going to do it a different way. You can't hear it, can you? No. Okay, bear with. I have to click something. I've just got to. Oh, just bear with me a second. I'm sorry. Right.
How will they collaborate with other parts of the system? And what will these changes mean for you and me? When the NHS was set up, it focused on treating single conditions or illnesses. Since then, our health and care needs have changed. Are living longer.
Right.
Big changes are taking place across the health and care system. What does this mean for the organisations that make up the NHS? How will they collaborate with other parts of the system? And what will these changes mean for you and me? When the NHS was set up, it focused on treating single conditions or illnesses. Since then, our health and care needs have changed. More of us are living longer, and many have multiple conditions that require regular, ongoing care. However, this hasn't been reflected in the NHS's structure, a patchwork of organisations that often work independently from one another. Navigating this can be confusing and can have a negative impact on our experience of care. So, for some years now, health and care staff and leaders have been working to bring organisations closer together to better meet our needs by working in a joined-up way. Primary and secondary care, social care, mental health and community health services have been seeking to partner with each other in different ways. At a very local level, GP surgeries have been coming together to form primary care networks, groups of practices working together across areas called neighbourhoods. By sharing resources and working closely together with other local people and services, they can provide a wider range of services than a single GP surgery. Health and care organisations have also been working together across larger areas called places, often covering the same area as a local authority, where large parts of the NHS budget are spent. Here, local government, charities, residents and NHS partners can work together to understand and meet local health needs. But previous laws have prevented services becoming even more joined up. The 2022 Health and Care Act aims to change this and make it easier for organisations to work together. But what do these changes look like? Organisations are now coming together across even larger areas to form integrated care systems, partnerships of health and care organisations that plan and pay for health and care services. There are around 40 integrated care systems across England, and although they've existed for some time, the Health and Care Act gives them legal status, as well as new powers and responsibilities. Integrated care systems are made up of two parts: integrated care boards and integrated care partnerships. Integrated care boards decide how the NHS budget for their area is spent and develop a plan to improve people's health, deliver higher quality care and better value for money. Integrated care partnerships bring the NHS together with other key partners, like local authorities, to develop a strategy to enable the integrated care system to improve health and well-being in its area. NHS trusts are also coming together to form provider collaboratives, new partnerships that can bring together providers such as hospitals, mental health services and community services. So how are these new structures funded? Integrated care systems get most of their money from NHS England, which is the national body for the NHS in England, and sets the operational priorities for the health system. It's responsible for the health services you and I access day to day, which are inspected and regulated by the Independent Care Quality Commission. The Department of Health and Social Care sets out what the NHS is expected to deliver for the money it gets from the government, which comes from our taxes. It also holds budgets for some of the other areas that have an impact on our well-being, like public health. Throughout these new structures, local authorities play a key role. They receive money locally and from national government, which goes towards funding a range of services that support our well-being and prevent ill health. So, what does this all mean in practice? The Health and Care Act has put in place a legal framework that enables services to work more closely together, so it's easier for you and I to receive the care we need, when and where we need it. For these changes to succeed, staff and local leaders will have to work with one another differently, alongside key partners in local government, the voluntary sector, and communities themselves. Of course, services face other challenges like workforce shortages, growing waiting lists, and the impact of the COVID-19 pandemic. While the new structures won't fix all these issues, by enabling services to work more closely together and join up services for patients, it's hoped that the health and care system will be better able to meet our changing health and care needs in the future. Find out more about how the health and care system is changing at www.kingsfund.org.uk/explain.
Oh, sorry. Right. Now, a presentation like that generally throws up more questions than answers. So I've just got a few slides I want to go through with you to give you an idea of why this is important to us in the Health Champions Network and stakeholder group. So just bear with me and I'll share that screen again.
Helen, it's Vaz. If it helps, do you want to send me the slides and I share them for you?
I've got it now, Vaz.
Okay.
Thank you. That would have been very helpful. Thank you. It is harder when there's only
When you're on your own, absolutely.
Yeah, that's right. And I couldn't get anybody. The person who used to help me has left. So, right. Thank you very much, Vaz. And I will take you up on that next time.
No
Right. Can I just check that everybody can see my slides now? Yeah. OK, so I'm not going to read this verbatim. You can see how because I'm going to share this with you and I've given you the links to the guidance. I'd just like to point out that the King's Fund is a charity and they are very, very helpful for navigating stuff around statutory sector services when it affects the voluntary sector and people's health. So I refer you to their guidance. I have also in these slides shared some links to NHS guidance, but of course that's the NHS perspective and is highly aspirational. And I know that we need to have more than one perspective, so that I do recommend the King's Fund. Now, this slide is just showing you that the voluntary and community sector, it's called the VCSE, Voluntary Community and Social Enterprise Sector, is central to what is the aims of the integrated care system. One thing I would like to point out is that when I go to quite a lot of the ICS meetings, an acronym called VCS is used and translated as voluntary care system or sector, and I am at pains to point out that there is no such thing. It is part of where care takes place in the community as part of the voluntary sector. It's part of the voluntary and community sector, and it's usually delivered through funding from statutory and other sources. But part of the problem with the ICS, one of the challenges, let's call it, is to do with jargon and terminology. So one of the reasons why we believe, certainly at EVA as an infrastructure organisation, why it's really important that each and every one of us involved in this understands in principle how it's all structured, is so that we can challenge misunderstandings. That's essential. So the voluntary and community sector is central to the delivery of this ambitious strategy. And there are 10 principles for that are given that the partners and the leaders will work to. And as you can see, with these 10 principles, equality and equity of each organisation's contribution is really important. And in the past, the voluntary sector has been sort of seen as maybe we receive some funding through CCGs or the local authority. We get on with things at a very grassroots level. But in actual fact, the voluntary sector is one of the experts and is one of the specialist parts of the system. And so these principles that the ICS is meant to work to is putting the voluntary sector on that footing. And that includes our colleagues on this call and other networks and meetings. And we've got some, I'm going to be talking to you a little bit later toward the end of the meeting about some free training that will support that. So just to put things into perspective, the Health Champions programme, which this network is about, is funded partly by the National Lottery, and then that was from 2019 for 3 years. Well, it's coming to a conclusion this year. And the North Central London NHS system, which is part of the new ICS structure, which that funding started last year. And the Health Champions programme is made up of 3 parts, as we know. The community participatory research part, which is delivered by Middlesex University, the Health Champions programme, which is delivered by EVA and that I manage, and a funding part called Community Chest and other titles. It's been badged up as different things, but there is funding that's part of that programme, and EVA has been administrating that. And many people on this call may have been recipients of some of that funding, but the NCL programme of work around health inequalities has had some other channels of funding, some other strands of funding, which other people on this call will have also received. So EVA isn't managing it all. Now, the theme that the Health Champions part of the programme is working to, as part of with the community participatory research and the community chest, is around reducing health inequalities, specifically in the area of childhood obesity in Enfield. And the strands of work are looking at obesity reduction and smoking cessation. And on the right hand side of this visual is the structure that the ICS system wants participants within these programmes to work to. So you can see it's collaborative, it's consultative, we're meant to listen to each other. Now, the thing is, if we knew what worked, we'd already be doing it. So a key factor about this programme, and amongst others, as part of its work in the ICS, is to get different outcomes. We have to do things differently. And this acknowledges that the people that are experiencing the challenges are the experts. They might not know what the solution is, but they certainly know what that solution would mean for them. So that's why the voluntary and community sector is so important, because the voluntary and community sector is made up of organisations large and small, some unincorporated, some highly sophisticated and organised, that actually has the ear and the trust of our residents. So as community and system leaders, which we are on this call to one degree or another, we need to be able to listen, learn, experiment, listen, learn, apply, listen, learn, and we keep on doing that until we get it right. So this is another visual that shows how voluntary sector and the community is meant to be engaged. And so this is an underpinning a principle, another principle of who should be involved within the work that we carry out. And in Enfield, just to give you an idea about some of the terminology that was used in that video, the integrated care system at system level is North Central London, NCL. The place that we are involved with is Enfield. The providers and provider collaboratives, well, the Health Champion Network and Stakeholder Group falls into both this section and the neighbourhood section, because we straddle across the two levels, if you like. But certainly the work that we do, the messages that we share, the learning that we have as a network and stakeholder group can be fed directly back to place level through the Integrated Care Partnership Board for Enfield, which I sit on, and other people in this call may actually also be part of. Right, so I said I was going to share a visual of the Enfield primary care networks, and that's this visual. So you can see that it's colour coded into 4 different areas of groups of primary care networks. 4 different primary care networks, which are 4 different groups of GP practices, and the list is on the right. Once again, this is here for you as a reference piece of material, but if you were interested in, or it was relevant to you as to which surgeries were in the area that your activities cover, then this map is extremely useful, and it gets updated from time to time. I'm not aware of an update since August 2021, but because when I last chased up for an update in December, this is the one I got given, but I keep an eye on that. So there are some resources here on this slide which you'll be able to access when I send the slides out to you. And EVA, we take it upon ourselves to read all this type of stuff and edit it down to something that's meaningful, because we haven't all we're not all time rich at all. And so I'm not expecting everybody to read this, but I want you to know that obviously I'm not making this stuff up, and that these are the source documents for what we are working within. Now, we're the magicians, because we're the people that work at the place, at the neighbourhood level, and we're the people who can make the magic happen. And certainly that's you guys who work within the programmes that are happening. So we've got we just wanted to showcase a couple of programmes that are happening locally. One is the Enfield Talking Challenge, I think I'm saying that right, and the other one is the Enfield Patient Participation Group Project. Now, is Christina on the call?
Yes, I am.
Yes, great. Okay, Christina, I'm going to hand over to you. Christina Lopez Paig, is that how I say it, Christina?
Yeah,
I only ever call you Christina, I never say your, yeah, lovely. So Christina is a GP or a GP at the Woodbury practice, aren't you? Yeah, that's right. So I'm going to hand over to Christina now, who's going to tell us about twerking. Now, I was fascinated with this because I was aware of twerking, not that I do it, but to me it was like, oh, is this like you know, community level twerking? But no, it's much more interesting than that. And if anybody doesn't know what twerking is, then you're not missing out on anything. And I did put a couple of links on the agenda for people to follow. But yeah. Christina, over to you. And then after Christina has finished speaking, we're going to talk. Litsa Worrell's going to talk to us. So, walking, what is it?
Let me see. Yes, the word is talking, which is talk and walk. okay, at the same time. So this was an activity that some of you, I know you're aware, I think Lisa is aware that because we have one PPG team in the talking participating, just to get the taste of it. This is an activity that it goes through an app, and you virtually walk from Enfield now to the highest peak in England, which is the Scaffold Pike, and you do it in teams of 3, and you can walk together or you can walk in different times, and then all your distances are added into your team, and the team moves in a in a virtual map, as I mentioned. Let me see if I can share some slides in here. The intention of this was to create a new platform for those who cannot join to the Enfield walks because they can physically not go at that time, at that date. So this is another approach, and also as a way of, because it's not only walking and talking, between your team and among different teams through the app, it's as well an opportunity of knowing other services that are available. And through the app, you lose, it's like more the personal side or the human side of health professionals, or you are directly in contact with other agencies because they are participating in there. We are sharing bonuses, pictures. So then it's easier for them to engage later on in other services. That was the whole idea. But let me see if I manage to share the document. Let me see. Please share screen, because that's not my usual presenter mode, PowerPoint, share content. Oh, can you see my screen now?
Yes, we can.
Okay, so if I do this,
yes,
slideshow. Yeah, can you see the talking now?
Yeah, we can see it.
Fine. So that was the idea. So if you see in the picture, you saw the idea is through walk and talk, you become, it's a way of going from being depressed, diabetic, abuse, smoker, any of these categories. Talking give you to a better independent life. Okay, and now it's on prescription. So this is in coordination. We created that from the GP side and trying to use this to connect with the charity side or any other agencies around. So it was a platform as well of an ICS model. Okay, so we are doing the pilot now. So I always do the same questions when I do this presentation, but in average, I would like to ask, and that's what we ask our patients. So how many days each week do you go for a walk outdoors? Okay, so everybody can check just how many days I go just for a walk in a day, in a week. And then on those days that you say, for example, it's 2 days, how many minutes do you walk for? Okay, so if we can do this calculation, then we will know how many minutes do you walk walking outdoors every week. Have you done this math more or less, and how much does it come? Some people, they say 0. I don't go at all. I just go by car, go to work, then, and if I do some exercises, all is in the gym. Can you tell me roughly? Can I ask if you'd like to? How many minutes do you do in general in a week? Anyone? It's brave to answer.
I think there's too many people here to answer that question.
Okay. Okay.
It's over 30.
So
Christina.
what we realized, sorry, 30 people. Okay. Okay, we don't have even one answer.
Christina, Bernie has put in the comments that he walks 630 minutes. I would say I walk about 120. So there's 2 of us. Debbie Gates in the comments has said 0. Louise Bennion has said 210. So we've got a variety there.
Okay, that's good, because what we see is that less than 150, which is 20 minutes a day, you are in the orange side. Okay, from 150 is when you have a good impact in your health. Although, as you know, all the studies now say that any exercise, any improvement, any amount Any amount of improvement will be very good for your health. Okay, but we all know that from the first 150 minutes are the most important ones. And why is physical activity important? So as doctors, we all know, or you as well as health champions, that it reduces hypertension, it reduces diabetes, type 2 diabetes, the risk of diabetes by 40%, depression by 30%, risk of falls by 30%. Back pains and joint pain, which usually is an excuse not to walk, it's reduced by 25%. And also some risk of some cancers, good evidence in colon and breast. And not only the physical activity is good, you know that if sedentarism by itself is a high risk factor for early death. Okay, so if you are sitting down 10 hours in front of the computer, as we do, you know, at least in my case, without any movement, then there is an increased risk of early death. So we know all of this, as I just talking from the health sector as doctors, but what do? We end up doing this, you know, all day in front of the computer, even knowing that this is bad for us, okay? And then what happens is, now and then we have this light saying, oh, we have to do something, and then we change and we think that physical activity is this. You know, and we, in our brains, we think that physical activity is going to the gym, start doing very high activity, you know, high impact activity, or becoming very muscle. And that's what people has in their brains. They think they relate physical activity with marathons, going to gym, being very powerful, when the evidence show that just brisk walking is enough, or walking is enough. Everybody at their own pace. Okay, and that's the message that we want to go across. Walking slowly, 20 minutes a day is more than enough. Okay, so that's why we created the Walking Challenge. As you can see here, the difference in health comes from the 0 to 150 minutes. After that, if you do more exercise, if you do more activities, it's fine, but it's not that, the increase is not as good as the first 150 minutes. And after 5 hours, and after 500 minutes per week, there is no evidence that you will be healthier than someone who is doing less than 500, sorry. From more than 500, there is no benefit or no evidence that is more beneficial than doing less than 500. But the major impact is here. So if you go from 0 to 20 minutes, it's better than 0. Okay, so with this, having this in mind, is when we created the Walking Challenge. So this was related to people who was carers, because they were the people who had major risk of not going outside and doing anything or any physical activity, over 60 because the risk is as well higher, people with chronic physical or mental illness, cardiovascular risk factors. So we make sure that each team had at least one participant with one of these conditions. And apart from walking, we also added the bonus care. Bonus care were activities that were adding miles, weekly miles, if you look after yourself. So either you look after yourself saying this week I will not eat crisps or I will not smoke. So if you have managed not to do that, you can add 7 miles. If you look after others, it counts. Like I've given a lift to my people at work, or I cook a recipe for them. So it's as well, because it's a well-being, giving others is part of the well-being, or looking after the environment. So those things in here also are part of the challenge and helps your, the teams to communicate in a different way. It's not just exercises, as well the social part. Those are examples. This is the one that we are doing now. So this, I just last night picked 3 examples. So the first one is a bonus about no biscuits for me these 2 weeks. So that person added 7 miles. This is, although it's not very healthy, I would say, but it says caring for others. So good vibes bonus. I baked a cake for my brother's celebration. So she made an effort to cook something and give that to her brother. And that's the bonus nature. We give a list of bonus nature, although you can be a bit creative. And one of them is just give a hug to a tree. And then you can add this weekly bonus. So that's the social part of this. And you share these pictures with others. So as I was saying, this is an ICS model. So we have now the leisure centres are part of it. We have a safeguarding team as well participating, EduCase participating. We have the PPG as well. We have different practice, different doctors participating in the challenge now. As I said, it's presented, and the intention is like a platform to, to do something together when we can, because as I said, the challenge is to do 20 minutes a day whenever you can. You can be lots of 10 minutes in the morning, in the evening, around the surgery. We are, in our case, we're just walking around the surgery, 10 minutes walk. We know now what to do, and now and then we break our day. So during the challenge, you will receive messages, and that's one of the examples. In here is when we cross the M25, so then we say, I think the first one, this adventure outside our comfort area. Now what we were trying to say is that now you are changing the smoke for good breathing, and then we give information about contact your GP you want to give up smoking. This is the link, National Smoke Helpline, and also we offer that's the Care Association that they do free yoga breathing techniques. So we are advertising free services in the area, and we do it with the smoking, we do it with diet, with healthy diet style, with any kind of classes, whoever we contact with, because we have been presenting to different agencies. When they were interested, we say, okay, what are you doing? We can put it on the challenge, and we always find like excuse. Like, oh, you are in Oxford, be creative, because a lot of authors in there, and then we send a link of all the activities, not all, but a lot of activities that you can do in Enfield. That was the referral, because everything goes through GP, so people want to do it, then they sent us a team with the 3 members, that's teams of 3, and then the GP contact us and we organize it. And that's all we are in. So what we were saying here is now is on prescription. So it's better than any tablet, I would say. And I think that's all we did. Yeah. So let me just go back to here.
Can you take some questions, Christina?
Sorry?
Can you take some questions?
Yes, of course. Yeah.
Does anybody, I have a few questions, but before I ask mine, does anybody have, thank you very much, Christina, that's fascinating. And because we know that the 4 main conditions that are the biggest killers in our communities are as a result of behaviours, what we eat, how much exercise we do, and smoking, then this is just, ticking all of those boxes, including the mental health one of reducing social isolation. I think it's brilliant. Does anybody have any questions? Please put your hand up, fire away. Can you stop sharing your screen, please, Christina?
Oh, did I not do that? Oh, sorry.
That's okay. Anybody got any questions? I can't see any hand. Oh, Joseph, you've got one.
Hi, Helen. Hi.
Christina. Josephine, my apologies.
Yes, hiya. I'm Jo Carroll. I work with Enfield Mental Health Services at Barnet, Enfield and Haringey. And I think this is absolutely fabulous if we can get people to access it and get encouraged by it. I was particularly interested in there has to be one person who's really resistant to joining and who really needs a lot of help, because that really pulls us together as a team to help each other. I think this would be really good to share and develop a bit, and I've taken some pictures, hope you don't mind. Because often, so thinking about our mental health clients, often they're isolated, they don't get out, sometimes their behaviours don't make it conducive to other people inviting them to things. So it'd be quite a nice piece of work for us to do with some of our mental health clients, I think, and for our staff.
Yeah, this is the engagement, as in everything, is difficult. It's very difficult, you know, you talk, is this an app or I don't know. So the app problems is part of the project. I always say to them, is part of the challenge, is part of the talking part, learning how. It's very simple, but we are all scared on that. So sometimes, as I said, it's challenging to get people in, but once they know, it's fantastic. So the trick in here is that you need some champion or some leader in each team. That's why these teams of 3. One is very, you know, up for it, and then, or 2 of them, and then they pull the third person. And now we are doing it in families or friends, and ideally, if we had volunteers, it would be even better. You know, in this, you as a voluntary sector, in your agencies, for example, it's easy. They know you, so you can say, okay, I'll do a team with you, and you know, we cannot just mix people without. We cannot make that decision because of all the GDPR and safeguarding and everything. But if you already are with those patients and this is sorted, then it's easy. You know, it's just, or if they are friends and the friends give us the team, it's easy. But as you were saying, Helen, you are the ones who are in the community, who know there are small charities, big charities, but they know their people. And from there, this is just a tool to offer. And I think very little it can do few teams. But it's challenging, to get people. I've been digging blood. You know, it's not just to try to find people to participate. That they are, you know, we are quite a few teams now. We are more 100 people now doing this one. So I hope in the next one, more people will join.
I think it's an excellent idea, and I've got some thoughts on that. Debbie, you've got your hand up.
Yes, thanks, Helen, and thanks, Christina. I really enjoyed your presentation. I was just thinking about how we may extend this new programme initiative to those with sort of mobility issues, disability. Is there any sort of thoughts on that?
Yeah, in these ones, as I said, this is done in teams of 3, where in average is 1 mile a day, but you don't need to do this mile. You can do less than that, and the other ones take over. So we want these people with less mobility to do a bit more that they would do if they were not in the challenge. So we don't want them to do the whole, everybody has to do their bit. You can do it in wheelchairs as well, is accepted, because fresh air is an impact. So we just want them to go outside. You know, sure. This is an excuse. This is not a marathon. We're talking about 20 minutes a day or 60 minutes between 3 people. So as long as you have someone doing more, and we give all kind of bonuses to catch up. We just want people to do it. Not there is no, you know, a medal. Yes. But yes, the important thing is that someone who would not do anything do a bit more. That's all. You know, so if, people with mobility issues, they should be encouraged, you know, to do something else. Just say, okay, as long as you just go and do 100 yards, whatever, outdoors. So it's enough to put your clothes in, you know, a bit of sunlight, that's all. We had even people doing it in the backyard, you know, or in the garden, that's all. And then you share your bonus. That's why the bonus is important as well. You know, because 7 miles, and only each person has 7 miles of each week. So it's important to at least to take a picture of that flower and share it with others, you know, because it will help your team. So, yeah.
Thank you.
I've got a question from Vas. Vas, you were first.
Thank you. Yes. Hi, Christina. Forgive me, I had to disappear for a few minutes, so you may have answered this in your presentation, but 2 questions. One is, I think you said that this is via, you get onto this programme via the GP. How does that happen? Is that something that you know, the GP is concerned about someone's obesity, diabetes, etc., and suggests this? Or is there another way? And the second question, which may be linked, is how is it promoted? How does the general public know about this?
Okay, so we have had quite a few meetings
in different countries, such as South Africa.
So in theory, all the GPs should know about this, but eye contact at PCN level. Okay, so I contacted, there are 5 PCNs now, so I had a meeting with all of them. The social prescriber in their PCN knows about this, and the health champion knows about this. So each PCN, the social prescriber should know about the talking, and I think the health champion in one of the PCNs as well. We are now in the pilot. You can go to your GP and say, I want to participate in the talking. They should know, because the only thing they have to do is to refer to the social prescriber, and there is a link that I've provided to everybody. But everybody, this is on there is a website with a link in there where you download the form and you just give that form to your GP, and the GP had instructions or the receptionist had instructions to pass this to the healthcare assistant, to the social prescriber, and then to us. But we may change the process as well, but they need to, health sector needs to be part of it. You know, it's because it's an ICS thing, and it's I think we have a bit of we are the opportunity of saying, look, this is another option, and we are getting there. More people knows about this, but you can be. We will change probably the circuit. So you contact us, you do the form, and then we contact GPs. Maybe that's easier.
So I'm aware of the program because of what I do, and as you know, but what I'm not sure about is how Joe Average will know about it in order to ask to get onto the program. I mean, is it a matter of having a poster up on the, in the practice waiting room, or or is there something, do we publish this in the over 50s forum, or it's just how do we get the word out?
Yeah, if you want to contact us, I give you the information. You can put it in your services, in your charities. I've done that as much as I could. I tried, Helen, that I've been just writing everybody, Lisa as well. I've been trying Fusion as well, but I don't have control of what happens at the other end.
So I can perhaps come in there. So Enfield Voluntary Action is an infrastructure organisation that supports the voluntary and community sector, and there are around 1,000 voluntary and community sector organisations in the borough. Debbie Gates on this call as well in the local authority manages a mailing list, as does EVA. Of those organisations, and this is the sort of thing that we could share across the health champions, which is a network of about 60 people, but also across those 2 mailing lists within the voluntary sector and stakeholders that I've just spoken about. So I think the important thing is, Christina, is that, and I'll come to you, Nikki, in a minute. I realise you've got your hand up. I think the important thing, Christina, is that the access to this service is very clear in your communications, because many people, including the over 50s people, will say to us it's impossible to speak to your GP. So if you can get referred onto this programme through, and I presume that's to do with managing statistics and targets and what have you, if you can be referred by your social prescriber, then maybe that is an answer, because patients do have phone numbers in some cases for social prescribers, so they're easier to get hold of than GPs. So we just need to have that clarified. And the second thing is if you can share your presentation with me, Christina, I will make sure that everybody on this call gets that when we send out the paperwork and the recording of this meeting after early next week. And then it's a case of us each talking about it to our stakeholders, because it is a brilliant, and I love the buddying nature of it, and the fact that you get bonuses and stuff. I know myself, it's like, oh, I can't be bothered. No, it's not so much I can't be bothered to go for the walk today, but I'll just put the washing on instead, or I'll just do this. And then before you know it, a week has gone by, and it's like, what happened to my 10 minutes a day? So I can see the value of it. Can I just take Nikki's question, and then I need to move on to to LITSA, but obviously, I mean, you know, let's have you back at our next meeting in October and talk about it again, because these meetings tend to have different people, you know, the same but also different people at them. Nikki, your question.
Yeah.
Hi.
So we
Sorry.
can communicate. Yeah, tell me.
Apologies for lateness. Just to say, I missed most of your discussion, so I just sort of came in at the very end, but this is a really good idea. We've set up something very similar. We set it up a couple of years ago when we had the pandemic, and we've done a neighbourhood watch group. So anytime someone goes walking, we're all on the app and we're saying, right, we're going walking. We've got a lady that's got a heart condition. She can only walk about 20, 30 houses down the road, and one of us comes back, walks her back to her house, and then we carry on. But we're also at the same time we're doing a neighbourhood watch. We're looking out for one another just in case there's anything going on, and we say, right, some of the girls are walking out now, anyone wants to just literally come to the door and just wave and have a chat with us, we do that as we speak. And the other thing I wanted to say was I'm part of the over 50s forum, so if you want to send me details, I'll make sure it goes into the next newsletter that they send out.
So if Christina, if you let me have that, Nikki is one of our health champions. So and anyway, she's attending today's meeting, so we'll make sure that gets circulated. Yeah.
Okay. Yeah, we'll send it. Yeah, because sorry, today I'm on call, so I'm just squeezed like I need an hour. I will do it at the end of today or tomorrow. I'll send out all the.
The recording won't be ready for me to be able to share until tomorrow or Monday, because it takes time. So early next week, and if I haven't had it, I will contact you. Okay. So what I'd like to do, thank you so much.
And if we can liaise.
Yeah, thank you so much. So what I'd like to do now is introduce LITSA Worrell. Christina referred to the PPG. What's the PPG? LITSA's going to tell us about it, and it's really important that our residents engage with this programme, if at all possible. So over to you, LITSA, and then after LITSA has finished speaking, we're just going to have a short comfort break.
Okay, thanks, Helen. Yes, Christina, I'm with you there. I'm just in the process of organising a PPG network. So I shall probably end up inviting you to come and talk about your twerking. I have to be careful what I say there, because I'm used to saying twerking and not talking. Right, okay, guys. Hi, nice to see a few faces that I know, and old faces. Bernie, nice to see you. PPG, patient participation groups. Every single surgery, I'll do a quick update. I know a lot of you are from the NHS, so you'll probably know about them, but every surgery should have a participating patient participation group, and you should be active. Over the pandemic, a lot of the PPGs weren't active, actually, because of not being able to get together. Maybe they couldn't do the Teams or Zoom meetings. So the role of a PPG is to actually support your local surgery. It's not about having a go at your surgery. All right, it's not trying to get your point across because you're upset with them. It's about talking about issues as a whole and looking at patients as a whole, not individual issues. If you've got an individual issue, then you go directly to your practice manager and talk to them on a one-to-one basis. But the PPG is there to support and make life better for the patient and also the practice, to make have a good pathway of services, and because sometimes you get so engrossed in your own work that you forget, and you think, oh, if somebody was to say to me, oh, have you thought about doing something this way, seeing patients this way? And as a practice manager, you may not have thought about that, or as a GP, and they think, oh, that's a good idea, we could do something like that. There are PPGs that have become constituted, and therefore they can run raffle prizes. There's one surgery that has actually sold raffle tickets to people coming into the surgery, and they've bought oh blimey, I can't remember the name of it. It's gone out. Sorry, it's COVID fog, or age-related COVID fog. Let's call it that. Defibrillator. They bought for the actual surgery. That's such a nice idea, such a good, excellent idea, and it's nice to see that patients and the surgery working together to make a difference to the surgeries. So that's kind of the PPG in a nutshell. But it is a serious thing. It's not just about raising money or doing that. It's about dealing with issues both together in a mutual fashion. So I am currently talking to all the surgeries in Enfield to find out how their PPGs are working, if they're working, what they need to do to make things better, how they can include people from different, from an equity perspective, so it's from different ethnicities, disabilities, mental health issues, how they can all come together and increase participation to be more inclusive. I will be writing a report, well, a sort of report. So it will be a report, whether I finish writing it or not, I don't know. About what the outcome is of the PPGs, because I think they can make a difference. And everybody I've spoken to so far, all of the surgeries said yes, they have made an impact, and they can make a difference. Some more than others, of course, but I've given them lots of advice of how to participate, how to include people. There is also training that we can offer. We've got some funding for training for the patients if they want to do chairing or minute taking, and as EVA have done this previously, so they've actually made specific training around PPGs to actually deal with this. We could also assist you to join the NAP, which is the National Association of Patient Participation Groups, and that's really handy for GPs to have actually have them join there. It's very little money. It's only about £40–50 a year for membership, but we could support you in this year surgeries this year if they want to participate. After that, you have to pay for yourself unless we get some funding for it in the future. I'm also what I've actually discovered a lot of like in the what we call the deprived area of Enfield, the Edmonton, you know, the old Backwoodale, is that there's a lot of Turkish speaking, Somali speaking patients that do not participate, and I would like either of these organisations, voluntary sector specifically, to contact me because I want to put a proposal to you about how we can take this forward and encourage participation. It's kind of like an idea in my head at the moment, but I think I would like to, and I won't be able to do it for every single community that we actually have, I'm afraid. Because there's just too many communities, but I just want to do a little pilot scheme and see if we can run, for example, a Turkish speaking PPG, and that would be across the board, but to look at, you know, across Enfield, but to look at issues that are coming through and then to put them through to individual surgeries. And I said, I'm only thinking on top of my head and I've got nothing worked out yet, but I have put this forward to surgeries and they're quite happy with that, and they're looking, they're quite seem to be quite interesting. But I need a voluntary organisation that we can support to be able to do that. When I say support, I mean financially support them to do that. I see there's a question. Nikki's saying, how do you find out if your surgery has a vacancy? I'm sure that they'll be glad to welcome you on board, Nick. I think there's only one surgery that I've spoken to so far that are full up from their constitution, but not everybody's constituted. For example, my organisation, my surgery is not constituted, so therefore that you know, you could have, in theory, you could have all of the patients participate, but you know that's not going to happen either. So I think that's about it. That's about all I want to say. Are there any questions? Let me just have a look at the chat. Suggested thanks, Bernie. Yeah. I think there are some Turkish-speaking organisations nowadays, I believe, but Helen, you'll be better off to tell me. But
yeah.
And so perhaps we could get together and talk about that.
Yeah, and Bernie tells us that Alev Kazimoglu is a good person to reach out to. Is he one of our counsellors, Bernie? Yeah.
Yeah.
And Nikki says that the Third Age Challenge group is a Turkish women's group that she thinks would be happy. And then Sival is here for the Turkish community. So
what I'm going to write my email address.
Please do. But after this meeting, I always share a list of the attendees with your email addresses with the papers, so that people can contact each other, because this is a network. So let's just put her email address in the chat, but you will also get a copy of the attendee list and all of the email addresses, so you can contact each other, because that's the point. There's no point in me being a bottleneck. So the ask is, if I understand correctly, you were very clear about the Turkish idea, and that sounds fantastic. But the ask is generally, I believe, Litsa, that more residents know what the PPG is and how they can get involved with their own local surgery PPG. And of course, health champions and voluntary sector organisations are ideally situated because they've got the ear of people that trust them. So if you've got some information, some updated information that you can share with me, and I'll make sure that it gets shared after this meeting with the papers early next week. And I think it's a recurring theme. We'll try and feature you again at the next meeting if you're free to join us. But this is all about, going back to the beginning of our presentation today, this is all about how we listen as a system to the people that are the specialists, that i.e. residents themselves, about their own health and what residents want from how healthcare is delivered and what have you. And not everybody's going to get everything they want, but the point is we're creating, and there are mechanisms for those voices, but those voices, nobody's a mind reader, so we need people to be engaged with initiatives like the one Litsa is leading on. So I can only encourage people to bombard Litsa with contacts and information, and she'll soon tell you when to stop if she's got enough to be going on with. Right.
Yeah, no, absolutely. Thank you.
Okay. Lovely. Now we're just going to take a short break, and then immediately after the break I'm going to show you a short film because we want to recruit some local film stars to make a film. So let's have a short break for 10 minutes. I will start the film at 11:20, and then we'll be moving on to listening to Patrick or one of his colleagues about the community participatory research, just for those people that have got to, I know there's 1 or 2 people that have got to leave. So grab yourself a glass of water or a cup of tea. See you in 10 minutes.
Can you help me? Oh, lovely. Don't worry, I'll help you with it.
Right, welcome back, everybody. A good story. Sorry, I'm monitoring myself on my phone. I need to turn it down. A good story galvanizes people into action. And a good story has, I understand, 5 main elements. I'm just going to quickly read them to you. It has characters. It has a setting. It has a plot. It has a conflict or a challenge. And it has a resolution. Now, we want to tell that story about what's happening in the voluntary sector's activities in our community in Enfield. So we have been given some funding through the NCL, so through the ICP system, to create a film. And on the call today, I think we've still got Colin. Colin, do you want to turn your camera on for a moment if you're here? I'm not sure is he still here? I know he had to leave.
Colin messaged he had to catch a train.
Oh, he had to catch a train. OK, so Colin is going to be our film director, and he is going to be filming people within the borough, a part of organisations that you may be part of or may know of that are achieving some amazing stuff in the borough around the issues of health inequalities. And we have a brief, and I will be putting up a slide shortly to show you, to tell you how to contact me if you want to be in the film. We are also contacting organisations that have been funded through EVA's Community Chest and other funding. Anyway, I'm going to show you a film now, which tells a story. It's not clear to start off with, or it might be to you, but it wasn't to me. But I think you'll agree with me by the end of it that it's a powerful film. So watch this film, and then we'll be doing a call to action for our own film. And by the way, we want to win an award, so our film's got to be bigger and better than anything else. Right.
Sorry, Helen, just to confirm, Colin has put in the chat a link to one of their films.
Lovely. OK, so people can click on that.
Absolutely.
OK, this film that I'm going to show you is an award-winning film, so that's why I'm showing it to you. OK.
If it's all right with you, I've been trying to fill this out, and I mean, I should be able to read it, but can you help me?
Oh, lovely. Don't worry, I'll help you with it.
So Penny and Tom will be coming round every week to read stories of you.
Look, I know you don't really like reading, but don't worry. This is going to be fun.
Which one would you like? That one. This one. When a dragon comes to stay, does she go roar and shout my way? That's just the way the dragons play.
Okay, so as well as slime, what else do you like?
Space.
Great. Astronauts experience the launch first as a low rumble, then the feeling of speeding up as the rocket blasts off skywards. Do you still want to be an astronaut?
Yes. Can I read to you today?
Yeah, of course. I'd really love that.
He dreamed how this star might be his friend.
I found a local reading course for adults.
For adults? Thank you, that's really helpful.
You're very welcome.
Mix the eggs, oil, water and cookies in 2 minutes. Oh, I like the look of this one.
That looks great.
His name is Neil Armstrong. He is the commander of this space mission. Come in. Are you there? I'm losing signal. And will you succeed? Yes, you will indeed. 98.75% of
Guaranteed.
Guaranteed.
Yeah.
Kid, you'll move mountains.
Well done.
Right, thumbs up, any good? Did anybody like that film? It's really good, wasn't it? I think it's brilliant. So great, getting some good comments in the chat. Oh, how many of us are crying? I know. And I don't know whether you picked up, but it was the mum who couldn't read as well, so she accessed reading support as well. So now, a film like that tells a huge story about what happens for people in communities, but it also tells a massive story about what your organisation is doing to help people in communities. It's all about impact. What is the impact of what you're doing? What changes as a result? So in Enfield, we've got some funding through NCL ICS to make a film. And we want to showcase your organisation's story, which will mean that we want to showcase the beneficiaries of your organisation's work. Not all of your organisation's work. You might be involved in all sorts of stuff. We just need to focus on one thing that's been impacted, which you have been responsible for or have been a catalyst for. So on the slides, on my next slide, there is a yeah, do you want to be a film star? If you would like to be featured in our film, we're going to be doing the filming in July and the editing in August. So if you can let me know by the end of next week if you'd like to be featured, and just give me a short reason as to why your story, your organisation's story, is a good one. And as I've said, there are the 5 themes around a good story, and I'll that will be in the brief that we will be sharing with you. But if you email me first, and then I'll send you the brief. But we want to be nominated for an award, so that's what we're aiming for. We're aiming to be telling a story so compelling that Enfield becomes a centre for film stars, and that's potentially some of you people on this call. Now, I'm going to hand over now to Patrick, if Patrick is here still. I realise that.
Helen, I'm sorry, it's Jenny. Just a very quick question. I'm sure you probably said it and I'm being a bit dim. The film, who, apart from winning an award, who's the target? Who's the target?
Ah, good point. Good point.
So that I know whether or not to decide.
Okay. The target is multiple audiences. We want to, so it's being funded by the health system so that they can see how their money is being used. So rather than write a report, which we have to do as well, but rather than go into loads of detail, we want the beneficiaries to be able to talk for themselves. So the beneficiaries of the funding are the local voluntary sector organisations, and the ultimate beneficiaries are the people within the communities that they that where change happens for individuals. So the film will initially be shown, it'll probably be launched at EVA's AGM in October, and it will be, if you like, launched initially or submitted to the integrated care system that's funding it. But the point of the film is we will retain ownership of the film, and we will use it to tell the story to whoever needs to hear the story about how brilliant the work is that's being done in Enfield. So is that specific enough for you, Ginny? We can just have this conversation offline.
I was it's the thing about the beneficiaries, and if I'm thinking counselling, the domestic violence work, and even the food bank, there's lots of reasons why the beneficiaries don't want to be public. So I'm going to.
Oh, this will be a public film.
Yeah,
this will be a public film. Yeah.
But it's helped me out with my dilemma. Thanks, Helen.
Okay, yeah, and maybe there's a need for a separate type of narrative around those ultimate beneficiaries, and I think that's something we would need to consider. Yeah, but this will be a public film. Yeah. Okay. Okay. I'm going to move on now and introduce Patrick, if Patrick is on the call still. Yes, there he is, Patrick.
Yes.
Yeah, sorry. Now, so at previous meetings, we have featured the development of the programme that Patrick is managing, and this is called the Community Participatory Research programme, which is part of the programme that the Health Champions that this network is about is funded through. So there are three elements. There was the community participatory research, which Patrick's going to tell us how that's going. There were the Health Champions, and then there is the funding for initiatives which will help communities change their outcomes around obesity and smoking. But Patrick's part of the programme is about actually finding out from residents what their thoughts, feelings, beliefs, expectations, hopes, challenges, and so on are. Patrick's programme is about training people within our system and members of the community to be able to turn information, a narrative, into data. Anyway, so earlier on in the year, Patrick was running the training for the people who are going to be community participatory researchers, members of our communities. And I know some Health Champions did access that as well. They accessed it so that they could help residents to access the training. But we're in June now, Patrick, so over to you.
Thanks, Helen. And I think I should be in, yeah, okay. Full screen. Thanks for the opportunity to update on this. So yes, the project is simply about equipping local people with the research skills and tools they need to be able to carry out their own research, and through it to understand, to get a sense of what they consider as the sort of most important or pressing challenges and priorities in their local communities. So I just thought I'll give a quick overview, just in case this is new to any of you here at the meeting. We started off last year in October, and have gone through phases of community engagement, working with very closely with Eva on identifying the key institutions and people and organizations and groups in the community, and engaging with them in order to recruit suitable people for training. And so between, I think we've had 2 rounds of training, starting off in January and finishing in April. So we've trained 2 lots of community researchers, and I'll tell you a bit about them in the next slide. After the training, we held a community co-design event in which the researchers presented their initial ideas about what they were thinking of doing, and had discussions with invited community people and organizations to add more flesh, structure, and direction to those ideas. And thereafter, they went away with us to develop their proposals into firm projects. And that is what we have been doing over May and this month. And from July, Well, from the last week of this month into August, they'll go out on the field into the communities to collect data, speak with people, and collect their data and analyze it, and then finally we'll report, pull all that together and come up with a report. So this is what the project is all about, and this is where we are currently in June, with a number of the initial projects having been written up and ready to go. Overall, we trained 25 researchers over 2 rounds. In the first round, we recruited 12, trained 10 of them. The numbers were small because I think the engagement and recruitment happened at the height of the Omicron surge, and then towards November, December, where people were more concerned about Christmas than about things like this. But in the second cohort, there was a more enthusiastic response. We had 25 people recruited and trained 15. So 25 altogether, different people, mostly women. We had 3 men included. Men tend to be, that's the common experience we have. It's harder to engage men in this in these sorts of projects. So, but fairly diverse characteristics. A lot of people from the BAME communities, which are our priorities. And so, again, we have a diversity profile, which not everyone completed, but understand that it's something that seems to be quite generic for several reasons, which I won't discuss here. Not all people are happy to provide detailed information about their characteristics. But for now, we've got a first round of 8 projects that have been developed and are ready to go. Potential participants have been identified or in the process of doing so, and the tools for data collection have been prepared. We're waiting on the final ethics approval from Middlesex University, and we'll start, I think the first of the projects plans to start collecting data from the last week of this month. What do the projects look like? I thought I would end with just a flavor of the sorts of things the researchers are focusing on. So there is
Patrick, excuse me, is this correlating to the slides, because we're still on the first slide?
Are you still on the first slide? Let's see, maybe if I go right, I might have to stick to that view. Yeah, okay.
And you were going to go on to the projects, which I think is your last slide, but yeah, I just wanted to let you know that we were still on the first slide.
Oh, thanks for that, and I do apologize. Yeah, so this is just an overview of the project and where we are. And this was what I was talking about, the number of researchers we've trained and the number of projects that have come up in the first lot. And finally, just a flavor of what they have come up with. Again, just to emphasize that this is, the council, the CCG have stepped back and simply said, let the researchers, come up with their ideas, what they feel, as Helen said, what are their concerns, what are their priorities, what are the sorts of issues they would like to, generate more evidence about. So it's things like, there is one project looking at the experiences of the Turkish community in accessing health and care services. There are projects around an understanding of financial literacy in the Black community and how it impacts on their health. And what sort of barriers you'll see from the projects that there's quite a lot around how people experience and access services, okay, and what they think the barriers are as well as what the enablers or facilitators are. And the whole idea is that, is to come up with really solution-focused data, that helps things that are, that can be actioned. And largely, these issues deal with, amongst the different groups that have been identified for research. It's really about how they access services, what their experiences of using those services, and also what some understanding of what the wider determinants are. So things like financial literacy, for instance, how does that impact on health? And so there are projects on looking at the use of maternity services. There are some looking at young people and their use of alcohol and drugs, as well as their health-related behavior around the use of gyms. What are their motivations? What are their experiences? Why are they doing this? And so yes, this is where we are. There's a couple of researchers who are looking at the use of food banks. Who uses them? Why? How healthy is the food there, and how does it compare with other forms of food sharing in Enfield? So these are the set of this is a set of 8 projects that are ready to go, and which we hope to begin data collection on from in the next couple of weeks. Hopefully, there are other projects still in the pipeline. We are time constrained, of course, on this project. It ends in September, and but we'll see whether, again, we know that we're also doing the data collection over the summer period, and but hopefully we hope that we'll be able to add, and I think, another 4 more projects to this, and in time for the end of project report in September. Thanks, Helen. Back to you.
Thank you, Patrick. Now, there was a question by Krasimira. Have I said your name properly, Krasimira? Yeah, good. She didn't really understand what data this is about collecting, and it's, I don't think you possibly at one of our earlier Health Champion Network meetings where the programme was presented. But if I can just read out what I've put in the chat with a few spelling mistakes, and Patrick can correct me, that the Community Participatory Research Project is about hearing from residents about how their lives actually are in terms of factors that impact health and lead to health inequalities, particularly in relation to increased resident obesity in East Enfield. National, regional and local policy is generally made by people in ivory towers, and by that I mean sitting in offices in Whitehall, in the local authority, in what was the CCG, who are using data that's not necessarily been gathered from the real life experiences of local people. So therefore, we have this situation where if we continue approaching challenges the same way, we will get the same outcome. And the outcome at the moment is that obesity is rising, and using public health measures, obesity is one of the factors that contributes to an increased early mortality for residents, but also increased long-term conditions like diabetes, like lung and breathing conditions like heart failure, cancers and so on. Now, so why is current policy not making any difference? We don't know. And that's why we want to hear from local people. If it was easy, it would be done already. And believe me, if it was easy, then the voluntary sector wouldn't have been offered the funding to look into it. So the reason, and Middlesex University, so the reason the CPR programme is training people in research principles and tools and skills is so that we can turn anecdotal stories and evidence into data, obviously with people's permission, that can then be used to influence how funding is used locally. And there is a concept whereby, if we think of a figure U, the letter U, policy is made at the top of the 2 points of the U. That's how it works. People sit up here and there's a problem, and so we have policy, and that results in things like the bedroom tax and other things. And my comments aren't political, they're just practical. Now, if we go down the U and listen to people, ask questions, sometimes we don't know what questions to ask, so we have to listen in order to learn what questions to ask, and continue asking the questions until we think we can't find out any more information, then that's called meeting the solutions as they emerge. Because what appears to happen is we find out at the bottom of the U, because we've listened, we find out that there are some factors that nobody thought of, like, for instance, IT, digital capacity. If you can only make an application online and none of your family have access to digital devices or don't know where the library is, and blah, blah, blah. So we find out problems and challenges that exist, which don't need national or regional policy. They need interventions that make a difference in people's lives. But we only find out about that if we understand what's happening for residents. And very often, a lot of people within the system, including me, I'm quite happy to say, I used to live in Enfield, but I don't anymore. I can't afford to live in London. So the point is that it's no point people like me or people higher up the food chain making assumptions. That's all very well, and it spends money and it writes documents and strategies, but actually we need the experts in people's lives, which is people themselves who are living their lives, to tell us more about their lives. And so that's what the community participatory research programme is about. It's about training individuals within the community, residents, to be able to use tools so that they can turn what they know and what they hear into data that is perhaps depersonalised. We don't need to personalise it, which can be used to inform local policy. Does anybody have any questions of that? Patrick, have I articulated that correctly?
Oh, yes, you put it very well.
Thank you.
Yep.
Does anybody have any question? That's why it's so important. But of course, as Patrick has found, it's not easy. It's not easy to get people to be part of this because people are private, people are scared of institutions, people don't trust systems.
Sure.
So if it was easy, it would have been done before. So that's why it's hard. But that doesn't mean, a bit like getting up and going for your 10-minute walk every day, it's worth it. It's worth making the effort. Did somebody put their hand up? Vass, you've got a question. You're on mute, Vass.
Sorry, I was just saying, I don't know if this is a question or what this is, but I'll just say the words. So this is about the research. Yeah, I'm wondering about the what next. How do we make things happen? Okay, and that's almost a kind of rhetorical question, because the other thing I'm thinking about is existing work that's already going on, like what you've already talked about, the smoking cessation, or what the cohort we're looking at is specifically the 18 to 45, I think, which fits into some of these age groups that you were talking about, Patrick. So that's already going on. So it's the people that are smoking who are living with obesity. So it's not two separate groups, it's the same group. Yeah, so there's already that work going. There's already the Black Health Improvement project that's also happening. So I think what this is a kind of, not a warning, but to say we need to make sure that we talk to each other so that we're not doubling up on work. There is stuff that's already going on. That what you're proposing is kind of rich information to help that. And if you're saying that this is going to finish in September, your work is due to finish in September, then I think it's an opportune time to kind of bring this work together and kind of help each other.
in answer to your question, Vas, this work is funded through the NCL Health Inequalities strand.
Right.
So that is all, it reports into the ICP, Enfield ICP board, and it's also funded from the same overall NCL pot as the what's it called, the Black Health Equalities
improvement.
Yeah, improvement. It's all part of the same program of work.
Cool.
So it is being pulled together. So the work that Patrick is doing is about setting up the functionality of community participatory research and getting a few things started to see how that works. But this part of the programme that we're in is the mobilisation plus a bit of activity. But because it's the funding for it started for the whole programme, the CPR, the Health Champions and the Community Chest, it started last August, September time, and it runs for 2 years. Patrick's part is running for about a year.
Yeah.
So it's about then what worked, what didn't, and how do we scale up? How do we continue it? Because we can see that we learnt this worked, that didn't. Why didn't it work? Can we overcome that? So it's not about changing anything radical in the first 2 years. It's about setting up ways of doing things differently, and there are lots of other bits and pieces that are also happening around that. And Enfield has received a lot of funding. If anybody on this call is interested in seeing the reporting, then I can share that, because I sit on the deliveries group and I sit on the ICP board, if you want to see how all the strands come together. But one of the things that we've really worked hard at is not to be doing things in isolation. And so I really appreciate your comments, and we are looking constantly at ways of making that happen. The thing is, though, is that voluntary sector personnel and all of us, whether we're voluntary sector or not, but a lot of voluntary sector people are actually not paid to be attending these meetings. They can't go to loads and loads of meetings. They don't have the time or the capacity. So it's important that those of us that are in sort of paid positions are able to understand the context and the matrix of this, so that we can pass that message on in networks like this. So this next network meeting will be October. It's kind of roughly quarterly each year, 4 times a year, and that gives time for things to happen, but we also have to be really realistic. But I mean, does that answer your
absolutely.
Yeah.
Absolutely.
I mean, and the Black People's Health Improvement Board, that has been set up relatively recently, and I would like in future to have somebody come to this meeting to represent them. But you know, we didn't have time to organise it unless somebody on the call is from that group. But no, we want to be able to. I go to Patrick's CPR steering group meetings. He comes to our steering group and network meetings. There are some of us who sort of float about a lot of things, but not everybody can do that. So
no,
yeah,
absolutely. And as you know, Helen, I'm kind of sat in the middle, and I'm just trying to make sure that everyone is, you know, that we're all talking to each other and we're aware of what's happening across.
Don't you worry, Vas. You are my go-to person. So
bless you. Bless you.
Yeah, Ginny, you've got your hand up.
Oh, poop. I meant to take it down when you made the point.
Okay.
You actually made the point I was going to make, and that this had come out of our NCLCCG meeting and stuff.
Okay.
Part of a process.
Yeah. So unfortunately, there has to be process because it's public money that's being used. It's taxpayers' money, and we have to be accountable. And just to give you a little bit more of an idea about how that works, and I'll share the structure chart with the meeting minutes. There is across the whole of North Central London something called the Voluntary and Community and Social Enterprise Alliance being formed. I sit on that group to represent the voluntary sector in Enfield, but I don't claim to represent everybody. I'm just a voice who will say, I know this, but I don't know that. So, and by no means do I claim to represent everybody on this call or whatever. But the point is there are structures in place to put the voluntary sector and to put community groups at the centre of what Vas was just talking about. So we won't get it right every time, but we're much more in a structure where we can learn and make changes as we go along that need to be made. Seval, you've got your hand up, if I've said your name correctly.
Hi.
Hi.
Patrick, can I ask 2 questions?
Yes.
One is, I'm for a Turkish community as well, and who is the responsible for, you are gonna start the project, you know, for a Turkish community, like experiences of accessing health care, something?
Yeah.
Do you know who is?
Yes, I do. So you are one of 2 of the researchers who have an interest in the Turkish community, and I'm happy to off this meeting to link you up, because one of the things we want to do is create synergy. So where people have overlapping, researchers have overlapping interests, would like to coalesce that into a single project, which gives it more critical mass. Right. So yes, I can pick that up with you outside the meeting.
Thank you so much. And the second one, you know, like for our projects as a health champions, you taught us how we can do like research and do it project. But you know, like to discuss and to create the path, do we need to contact with you, or you know, whoever we can start, you know, at the beginning to discuss which path we need to go?
Yes, so that's right. There is if you recall the overview I showed, there was a phase of development of the proposals. It's something that Middlesex supports the researchers with, and that has been ongoing. I know that I think you were away for some time or so, but we've been holding drop-in sessions with all the researchers as an ongoing process to work out the logistics of the research they want to carry out. So if you, just contact the team, and we can take forward the bit you are interested in.
Thank you so much,
all
of you.
I mean, just to mention that Siva was one of the researchers trained from this project.
And as part of our ongoing, I mean, maybe we can feature something about the programme in our film, because it would be really good to hear from the community, the ones who have been trained, as to how that's changed their perspective. I think one thing I'd just like to point out is if you heard Patrick mention the ethics committee. So the thing about research and data, if it's going to be used by epidemiologists and people who make policy, then research has to meet certain standards. It can't just be this chap down the road said this and therefore we're going to, you know, do this programme. And one of the things that research programmes have to meet are the ethics committee standards. Now, you know, that's why having Middlesex University as a partner on this programme is so important, because Patrick knows all about that and he knows how to make that happen. And so therefore, what Sival and other people on the programme are pulling together as knowledge and information that gets turned into data, that will be utilised in decision making, because it will be turned into data that in a way that has been approved for this programme by the ethics committee. I mean, I'm probably not explaining it as well as Patrick could, but the point is that not everything is as straightforward sometimes as we think it is. It's not just about having voice, it's about having that voice in a way that people who hold the purse strings will listen to. And there may be some people on this call from parts of the system that hold purse strings, and they will know what their constraints are. Commissioners and so on will have constraints. So it's all about working within that framework without letting that framework be our master and stymie proper, thorough, true innovation. So that leads me nicely into the next thing that I want to talk to you about. If Patrick, if you've finished and if there are no more questions for Patrick. Okay, thank you, Patrick. Right, I'm going to just share my screen with you in a moment. Now, we've talked about the system today, about the changes that are happening within healthcare. So integrated care system, and at system level locally, that's North Central London, which is 5 boroughs. Enfield is one of those 5. We are part of the Enfield Directorate for the ICP, which is the Integrated Care Partnership. And the Integrated Care Partnership includes the local authority, public health, adult health and social care, children's services, the NHS, secondary care, primary care, mental health services, the voluntary sector, large charities that are constituted and registered, unconstituted voluntary sector organisations, unconstituted tiny little neighbourhood groups that don't even perhaps appear on the radar yet, and everything in between. So that's the partnership. But how do we navigate that? How do any one of us really understand what's happening? I mean, the NHS is, I think, the biggest employer in this country. It's a massive organisation, closely followed by the civil service, although yes, the various aims at reducing the civil service, but then I'm not going to get into that political discussion. So how do we navigate or understand the system that we are trying to change from within? Now, there is a free training course that's new, being delivered by the NHS's Leadership Academy, and I'm just going to bring my slides up. Okay, now this is a certified course which is free to access, run by the NHS's Leadership Academy, and that the Leadership Academy normally focuses on sort of middle to senior level personnel within the NHS, but this programme is all about facilitating collaboration for health and care, which is no longer just an well, it's never been just an NHS thing, but it's about including all parts of it: public health, which is in the local authority, adult health and social care, children's services, which are in the local authority, and all the plugs that, all the gaps that the voluntary sector plugs. So this programme is open to anybody that works within voluntary sector partnerships. So that would include persons on this call. What it means is it's not open to members of the public who are just a member of the public. You've got to be part of an organisation that is part of the collaboration that's going ahead. And collaboration at place level, as we discussed earlier, is acceptable. And this training is all about crossing the sort of professional, organisational, hierarchical boundaries to be able to design and deliver better health outcomes for the communities they serve. So I think that this programme, it would be of interest to anybody on this call. The programme will look at what system leadership is, why it's important, and how we do it. So there will be benefits to you as an individual, obviously, because you'll get a certificate for completing this course, an NHS leadership certificate, which is, you know, considerable in its importance for personal development and other opportunities, but also for your own organisation. It puts your own organisation in a position where you understand what the changing system is all about. And just because you've worked across the system for many years doesn't mean you know what it's all about at the moment, because the health and social care system is going through the biggest changes it's gone through in its 70-year history, and it's got massive implications for the future. So we're either part of the change or we get left behind. So the cost is free, but you must be part of a voluntary sector organisation. The programme is hosted on FutureLearn, which is an online learning platform which some of you may or may not have accessed before, but we will give you some support in accessing it if you need some help navigating it. If you want more information, then please email me. This is a brand new training opportunity. It was literally launched on Monday, and it's just in its beta phase, so it's not quite in its, well, it's on FutureLearn and it's been launched, but the system leadership for this programme are interested in just just finding out who is interested in joining it. You can join it at any time. It's a rolling programme. You don't need to like there's, it's not like it happens in June and then in September and so on, and it requires about 3 hours a week, and I think it's for 8 weeks. I'd be corrected on that, but if you I've got the brief. If you contact me, I will send you the information, and all I will do is keep a note of your name and your organisation so that we've got some information to feed back to the Leadership Academy, because we want to be able to help them to influence how it's delivered. Now, at the moment, if you register for it, you will get rejected probably unless you've got an NHS email. And then you have to go through to another screen where you put in your email, the name of your organisation and a brief description of how your organisation works within the health and care system. And when I navigated it, EVA is only a small charity in the scheme of things at local level, at place level, and my application using my EVA email address was accepted. Now, where you might be part of an organisation and you've got an email address that's a Hotmail or a Gmail or a Yahoo, or you're using your personal address, and this is a challenge with voluntary sector set up sometimes because people using their personal addresses, then that's what we've got to navigate. But that doesn't mean you can't do the course, but I'll want to know if that's how you're going to access it, and you'll need to set yourself up with a FutureLearn account, which is simple and free if you haven't already got one. So I've already put my contact details in the chat, so it's h.price at Enfield va.org.uk. If you're interested in this programme, email me and I will share the information with you straight away, and we will take it from there. But the more people that access this type of free leadership training from the NHS, it makes our local activity and our knowledge at place level, at neighbourhood level, much more powerful, much stronger, and it helps us to be able to be a greater voice, because one of the main challenges of the integrated care system and the integrated care partnership at neighbourhood level, at place level to at borough level, is that we don't always understand all the jargon. I definitely don't, that statutory services use, and they certainly do not understand the jargon that we use, and so acronyms get used that are misinterpreted or misunderstood, and then further misinterpretations down the line. Funding can be impacted by that because an assumption was made about an acronym. So the fact is that the more we can learn as individuals within our organisations about the system that we could help influence change within and access funding. We don't want to be owned by the system, because the voluntary sector's strength is that it's independent. It's like herding cats sometimes, but that's great because it means we represent the communities that we also serve. But we do need to understand, be part of the journey together, and we want and part of the leadership programme will be about being present so that we can say, hey, I'm from the voluntary sector and that's not what that means in our part, and so we can help also influence how this leadership programme will be developed. So you might not want to do it this time, you might want to do it later on in the year when it's been developed a bit more, but if you do want to have some reading for on the beach over the summer or for in the garden, then please contact me and I'll link you up to it. Right, does anybody have any questions about that? Okay, right. Do I know the starting date for the course? It's rolling, Krasimira. It's rolling. You just start at any time. Yeah, it's a self-directed course. So email me and I'll send you the brief, and you can have a look at because the email that the information that I've got has got a course overview, so you can have a look at what it includes. Okay. Okay, now, well, 12:10, that's nice. We're working within time. I don't have anything else to add today. The next meeting is Thursday, October the 20th, and the link to sign up for it was on the agenda. It's also at the link on Eventbrite, and all the dates are on there for the whole of the programme until next year. If anybody has any subject matter that they would like to hear more about at the next meeting or in between time, then please ask me. Health inequalities is a huge subject and we focus on certain things, but you know, we don't claim to meet everybody's needs every meeting. So if anybody thinks there's some gaps in information or information sharing or whatever, then please contact me. I'm more than happy to take nominations for speakers at the next meeting. I will be sharing the information, sorry, the recording of this meeting and the papers related to this meeting out next week. But if you'd like to be in the film, then please email me as soon as you can, because we want to set up some filming dates in July. And my email address is h.price@Enfield, V for Victor, A for Andrew, .org.uk. Has anybody on this call got any other business they would like to flag up? Any meetings that are coming up, any events, any community events, any calls for action, any asks from the people on the call? Yes, somebody says, can we have Patrick's slides? You'll have all the slides. I shall nag the presenters for their slides. Sorry, just looking at the chat. Oh, OK. The current big issue is the government's cop-out in the food strategy. Can we consider VCS responses in October? Yes, and what we can do is I can connect you with the Enfield Food Poverty Forum if you're interested, Bernie. That might be the outlet for that. OK, well, we'll do that. Ginny announces lunch. If only we were in the room, we could say to Ginny, what is she giving us? So, but as it is, we will have to organise it ourselves. At some point in the next few months as well, it'd be good to have a physical event that we will set up in Enfield. But for now, the next meeting will be held online. OK, thank you very much for the feedback that's in the comments. I don't mind some constructive criticism either, and thank you for bearing with me for being both facilitator and administrator. It's a bit difficult doing both, but anyway, we managed to navigate it. Right, oh, thank you very much for the claps. OK, well, enjoy the warm weather, be safe, keep hydrated, look after yourselves and your families, and I'll be in touch soon. Thank you.
Helen. Thank you, everyone.
Thanks, Helen. Bye.
Thanks, Helen. Bye-bye.
Bye.